top for the annual meeting, or it's for anybody, nurse practitioner or physician. Okay, so welcome to the afternoon. I'm going to just ask for a quick poll. How many people are NAPNAP members? Can you raise your hand? A lot, wow. How many people are SDBP members? Very good. And then how many are going to be going to the SDBP meeting this weekend? Okay, I just want to invite everybody who is interested to come to the Advanced Practice Nursing SIG Special Interest Group on Sunday at lunchtime from noon to 1. Bring your lunch, but it'll be a great meeting. Thanks for being here. And now I want to introduce the president of the National Association of Pediatric Nurse Practitioners, Dawn Garza.
I always have to come up the stairs carefully because my superpower is tripping over things that don't exist. I'm really excited to see you guys here, and I'm really honored to be here. Behavioral health is, developmental behavioral mental health for kids is one of my personal passions. So I'm thrilled to be here, and I'm not going to take a lot of time because we all know that if the afternoon is half as good as the morning, we're going to have an amazing day by the time we walk out of here today. So with no further pomp and circumstance, our speakers this afternoon, obviously we've already been introduced to Casey Krieger, who's a psychologist. We have Dr. Tanya Froelich, who's a physician, a developmental behavioral pediatrician. And then we have a past president of NAPNAP, Dr. Susan Van Cleve. Thank you.
Hi, everyone. My name is Susan Van Cleve, and I am, I think most people here are nurse practitioners. How many pediatricians in the audience? Oh, good. We're so glad you're here. We really appreciate you joining us. I just want to make a mention that I work in an integrated primary care practice where I have integrated mental health into the primary care setting. So my perspective is going to be a little bit different than my fellow speakers, Tanya and Casey, who are developmental pediatrics based. So I hope that that works pretty well for us in terms of our little differences that I will point out. I also just want to thank everybody from the Society for Developmental Pediatrics as well as NAPNAP for sponsoring this conference today. I think it's really great that we're doing this collaboration. I know when I was president of NAPNAP, we were starting to do some collaboration, and to see it come to this fruition is great. So I'm really thrilled to be here. I'm always intimidated about speaking in front of my colleagues, and so I just need to take a deep breath and I'll be fine. Okay. In terms of disclosures, I don't think any of us have any, but I do want to mention that we will be talking a little bit probably about some off-label use of medication, just in the event that we do that. So the goal of this afternoon is we're going to be going through a case, and we're going to be really trying to talk about ADHD. Most of you know a lot about ADHD, so we'll make some assumptions that we'll travel through some of the diagnostic stuff pretty quickly. But we do also want to talk about the use of screening and assessment tools in terms of ADHD as well as the comorbid disorders. Casey, what I'm really thrilled about is Casey's a psychologist, and she's going to talk about learning evaluations, and that's something that I know in practice I sort of struggle a little bit, is reading them and understanding them, interpreting them. And then using therapeutic interventions in practice as well as psychopharmacology. So we're going to use our case. Our case, the patient's name is Luke. He's 12 years old. He's a male. He comes to your practice in primary care. He presents with headaches and stomach aches. After obtaining further history and performing an exam, you rule out a physiologic reason for the headaches and stomach aches and discover that the symptoms appear in the morning and are associated with not wanting to go to school. He is always tired. So what would your next step be? So we have little quizzes. I think for those of you who are in the morning, you know about the audience response system, so everybody should have a clicker. And so if you could go ahead, and you'll have 10 seconds to go ahead and click on the correct response. Oh, there's some excitement out there. I hope they're cheering for us, right? Okay, so the answer is D, all of the above. That is correct. You're going to reassure Luke and his parents that he appears to be physically... I'm sorry. Actually, you don't necessarily, you could obtain a CBC in ferritin. I don't think that was our goal, but that certainly would be reasonable to do that. Obtain a further history about sleep hygiene, obtain further history about school avoidance, and it is all of the above. Sorry, I apologize. So, definitely. Okay, now on obtaining further history about sleep hygiene, you understand that he spends a lot of time in his room. His usual bedtime is 10 o'clock, but most nights he ends up playing Fortnite video game until 2 a.m. because he can't sleep and he has no snoring. So how many of you are dealing with Fortnite? Oh my gosh. I can't tell you how hard this is. I mean, I think it's really hard for us to make recommendations to parents. I think it's really hard for parents to try to deal with it, how to deal with the whole Fortnite thing. It has become a total obsession. I read an article in the New York Times recently that talked about how Fortnite is now really a huge problem in terms of gaming addiction. So anyhow, we'll just keep going on that one. But anyhow, we know that he's in his room, he's not sleeping well, and he's playing a lot of Fortnite. So you obtain a further history, and you find out that Luke is failing some subjects in school, and the school is concerned that his absenteeism is contributing to his academic failure. He moved to the area last year to live with his father because his mother could not control him anymore. He was diagnosed with ADHD in 3rd grade and had help with a behavioral support plan and a resource specialist at his old school, but he did not want to get special treatment in his new school. So, in obtaining further history from the parents, separate from Luke, you learn that in 4th grade, he was started on long-acting methylphenidate, 18 milligrams, 27 milligrams, and then 36 milligrams. The parents report that Luke did well in his old school until 5th grade when he stopped doing his homework. And the father reports that his presentation has changed from no longer hyperactive, and that the father says he can focus for very long periods of time on his Fortnite and other video games. And his father believes that Luke is just lazy. How many of you hear that all the time from parents? I hear that a lot too. Okay, so what would be your next step? So I'm going to go ahead and press the button, and you guys can answer. You can read these answers. Okay, so both B and C, that's correct. So we want to obtain Vanderbilt rating forms to confirm the diagnosis of ADHD and restart him on his previous dose of Concerta, make a follow-up visit, suggest the family give the school a copy of his old IEP and request it to be implemented, and then counsel on sleep hygiene. I know that there was some discussion about sleep hygiene in the previous morning, so we'll talk a little bit about that. So basically, I just want to make sure everybody knows what are the hallmark symptoms of ADHD. Again, if you can use your audience response system. Yes, I'll read it. A is hyperactivity, impulsivity, distractibility, and short attention span. B, hyperactivity, tics, short attention span, distractibility. C, short attention span, distractibility, panic attacks, and sleeplessness. D, short attention span, sleeplessness, tics, and distractibility. 97% say hyperactivity, impulsivity, distractibility, and short attention span. So that's correct. Those are the hallmark symptoms. So I think if there's anything to take away today, it would be this slide. And ADHD, when you think about ADHD, always think of it in terms of a functional impairment, which means that we really want to know if a child is acting fine, doing well in school, doing well with their peer group, but a little hyperactive or impulsive, and then that is not interfering with their functional impairment. But when one area of their life is interfered with because of either their impulsivity, their distractibility, their short attention span, then that is when we need to do something about it. So it's really important that we think about that whole term, functional impairment. Is everybody comfortable with that term? Use that. I think it's a very helpful term to use with parents when you're talking about why it is that you want to do something for this child, because their function is not within the normal limits of what it should be for their age. So these are the diagnostic criteria. I don't need to read them to you, but we know that when the DSM-5 changed, it went from 6 years of age to 12 years of age that they could have symptoms present, and that the symptoms are present in 2 or more settings. And so that requires that we then evaluate kids in more than one setting. We're not just going to evaluate them from the parent perspective, but also from the teacher perspective. And that there's clear evidence that these interfere with the quality of life. Now here's this is, you probably can't read this, so most of you, are you mostly comfortable with diagnostic criteria for ADHD? If you're not, the easy way to look them up is just look at the Vanderbilt scales, and they list essentially the criteria for ADHD in the Vanderbilts. So that's a nice, easy little cheat sheet. If you're asking questions and you're thinking, I forget to ask what question, just look at the Vanderbilts and you can ask those questions. So the kids need to have 6 or more symptoms of inattention up to the age of 16. And the first list is the inattentive symptoms. The second is the hyperactive and impulsivity type of symptoms. And so, we need to go through that with parents. We can use the Vanderbilts as our adjunct. And here's more. So you're probably aware of all of these. I think the one key question around impulsivity and hyperactivity is often on the go, acting as if driven by a motor, because that's really very common. Parents will report that that's been going on since kids were walking. You're probably all familiar with the Vanderbilts. Here's a link to them. And we know there's parent initial and follow-up, teacher initial and follow-up scales, and that we know that the Vanderbilts also screen for coexisting conditions. And I think this is a really helpful part of the Vanderbilts, because a lot of times parents don't really recognize that their kids may have anxiety and depression or ODD, and so it's a really nice, useful screen that we can use to identify that. It sort of tells us what to look at a little bit further. In terms of the ages, for the Vanderbilt scales, I've had a lot of questions when I do talks about can we use them in other ages, and I've really looked that up a lot, and I haven't found strong evidence to not use them. But I know in practice I will use them for 4 and 5-year-olds, and then again over 12 for high school. Do most of you do that as well, or no? Tell us. Anybody? You use the preschool ADHD rating forms, and that's great to do that. So I think that, again, it's the evidence says 6 to 12, but I do hear of people using them for different ages. Now, in terms of the Vanderbilts, one of the questions that I have had people ask me is, do you always use the initial Vanderbilt rating scales or do you use the follow-up ones? And you can use either. The follow-up ones are a little bit easier to use. They're the fewer questions. It is nice if you use the initial ones for repeat evaluations that you're comparing the same form one to the next. I don't think it really matters, but I do think it's important that you recognize the difference between the follow-up forms and the initial rating forms. So Luke, let's go back to our Luke. We have a follow-up visit in primary care, and now we have the initial rating forms for the Vanderbilts. And as you can see from these, and if you know about the scoring, these are pretty significant. So a 9 out of 9, or anything from a 6 to 9 is significant. So for inattentive symptoms, he's very significant in the sense that his father, mother, and teacher all endorse that. For hyperactive symptoms, his mother only supports that. He clearly has some ODD symptoms that seem to be worse with his mother. Not enough of conduct disorder symptoms to be significant, but the teacher is describing oppositional symptoms. He has a high score on his anxiety, depression, and his school performance and his behavior are all very high as well. So this is pretty concerning. He has a lot of issues going on. So in our follow-up visit, he comes back, and he's now taking his medication, and he feels as though he can focus better, but he's having trouble completing his assignments, and he feels lost in this new school, a relatively new school. So on reviewing his forms, he continues to have the symptoms that we just talked about. And so we know his school failure is concerning for a learning disability. So you decide that Luke needs a higher level of care. What would be your next steps? A, if you had the following resources available, you would B, refer to child psychiatry, C, refer to neurology, D, refer to developmental peds, or E, refer to all 3 specialties to see who would see him first. Okay, so go ahead. I'll be interested to see what people say, right? Okay, so 76% said refer to developmental peds, and then the rest to other areas. So I think this is really dependent upon what your resources are in your area. How many people have access to developmental pediatrics in their area? Okay, so not everybody. So if you do, how long is your waiting list? I'm just curious. How long? 6 months? 12 months? 4 months? Okay. So I think that's sort of the norm across the country, that people have a very long wait to get into developmental peds. So this is where you in primary care need to really take some action. You just can't say, we're going to wait 4 months before we get your child evaluated. So that's why you're here today, right? Is so that you can take those next steps and start that evaluation. Certainly there are, how long are your waits to child psychiatry? A year? What else? Anyone else? 2 months. Okay, so not so bad. So it just depends, again, upon where you live, what your resources are. And so depending upon what the best access is to, you should make that referral. But in the meantime, I think it's really incumbent on you to help that family until they get that appointment for the specialty practice. Okay, so you need to know what specialties diagnose and manage conditions in your area. And you don't want to refer to all of them at the same time because it's often duplication. So you just need to figure out which is the most likely one for them to get into. Okay. So we are really going to focus on developmental peds. This is a developmental peds conference, so that's what we're going to focus on today. So fortunately, you have a very short waiting list in your developmental peds referral. So you're going to make a referral. And what is helpful when you do make that referral is that you list out, you identify the concerns. You talk about the fact that the meds are not, he's not responding to his medication. He still continues to have other symptoms, including anxiety and depression, academic failure, school avoidance, does not have a current IEP. And you send copies of any screening tools that you've done to the specialist. And so the DBP staff, we hope, will go ahead and get all the copies and obtain a copy of any of previous psychoed evaluation that was done, and have the parents get the IEP, and to, if they had a previous IEP, to bring that, and that the DBP clinic can also ask the parents to start the process of the reevaluation in this new school. So Luke's family discovers this 6-month wait list to be evaluated and sends a letter to the special education in school. Okay. So all of this stuff gets sent out ahead of time. Now, if you're in primary care, and this is where I want to diverge from the slides for a minute, it's really important that you figure out a system in your practice for these follow-up forms for using Vanderbilt's, because this can take time, and these need to be scored, and you do need to get this information to make an accurate diagnosis. So that means you have to alter your system and have a system plan in place so that you can obtain these Vanderbilt's and this information from schools, because you may have a wait list. And if there is a wait list, again, it's incumbent on you to make sure that you are addressing these issues. So whether that means you have a nurse who calls the school and gets the permission, or you have somebody in your practice who gets that information, you really need to have a mechanism in place for how to manage those forms, because as you know, it takes time, right? And time is our biggest enemy in primary care. So let's see. The other thing that the that the developmental peds will probably do is a developmental intake questionnaire. And this is generally just sort of an overview of what the concerns are from either the teacher's perspective, the parent's perspective. And they may send out something called a BASC-3, which is, I think we're going to talk about later. Casey will talk about that. She talked about that this morning, which is an overall screen for development. Okay, so you review the intake questionnaire, and you find out that he went to 6th grade in a public school, and his grades went down last year after he moved to the new school. He doesn't have many friends. He used to play soccer and baseball, but he's not interested in continuing these activities. And this is really, I think this is very common. And so this is a little red flag, I would say. When kids stop their activities that they were very involved in before, that's something that you need to pay attention to. The sleeping continues to be a problem, and we know that this is a huge issue for kids with ADHD, but with all kinds of neurodevelopmental disorders, as they talked about this morning. So, always ask about sleep. Also, constipation. How many kids have constipation? Like every kid, it seems. So ask about their diet, ask about what they're drinking, what are they eating, how frequently they have a bowel movement, and then we find out that his parents have dietary concerns. You also always want to look into the past medical history and find out what could be contributing to this, and I know Tanya's going to talk a little bit more about that. But also the family medical and mental health history, because we know that many kids who have these disorders have relatives who have depression, anxiety, bipolar disorder. So always get a good family medical history. We want to make sure that we understand the context that that child comes from. If you have an adolescent, you want to interview them separately, and that's really important to do that, and also talk about confidentiality with the adolescent, that there is some things that you may need to talk to the parent about if that child is at risk for harming himself or someone else. Get a good medication history. A lot of times parents don't have that information, but you want to get that as much as you can in terms of dosages and frequency and how long kids were on meds and what worked and what didn't work. And then you're always asking questions about diet, elimination, sleep, exercise, screen time, big issue, family relationships, what's going on at home, is there any trauma that this child has experienced, is there any social discord with a family, and then in terms of school, how is the child doing academically and with peers. So after you meet with Luke, you discover that he reports having trouble focusing on his work, and he thinks school is boring and pointless. He tries to go to bed at 10, but he can't fall asleep because he's so stressed out about having to read in front of the class and worries about getting made fun of. So he clearly has some social anxiety here. And he worries about always being in trouble and says nothing good ever happens to him. So in addition, what you hear from Luke is that he plays video games online, and he hasn't made any friends since he moved. I think one of the hard things about Fortnite is that the kids will say, well, I'm playing with my friends, right? Do you hear that? And that's my new social context. And it's a little hard to know how to respond to that, because they really are talking to each other, and they really are playing this game, and the kids will leave and go to their separate homes, but yet they're still in touch with each other. So it's a little hard to address that. He's getting in fights at school, he doesn't like his teachers, and he's expressed some feelings of hopelessness. He feels stupid when he can't keep up with the other kids in his classes. So this is really pretty concerning, right? I mean, I'm concerned about him. So what are you most concerned about? Here's our quiz. Okay, great, both A and C. So we don't ever want to call a child lazy. I think we all know that. But we do have to sort of respond to that when parents do that for the kids that we see. Okay, so one of the most important other takeaways today is that if you have a child who has straight-old ADHD or ADHD of any type, you want to always evaluate for other comorbid disorders, because most kids often have some sort of other comorbid disorder as well as their ADHD. And so we want to think about emotional, behavioral conditions, developmental disorders, and then also physical conditions. So a couple of things I think Beth went over this morning already about the sensory integration disorder, and so you probably want to ask questions about sensory integration. Does this kid have problems with tags in their clothes, or oral aversion, or sensitivity to touch? And if so, then it is helpful to refer to OT. And then also we want to consider autism spectrum disorder. So ready? So Tanya's going to speak now.
So I know this morning you guys went over some fantastic information about how autism spectrum disorder is presenting more in the younger child. And so we're going to talk just very briefly about how things might look in an older child and how you kind of parse out, is it ADHD only, or is it ADHD plus an autism spectrum disorder? Because as we know from our clinics, social skills are often problematic in ADHD, even when autism is not present. Just a quick point, though, about when kids do have autism spectrum disorder is extremely, extremely common for them to also meet criteria for ADHD. And in fact, most studies are indicating rates of ADHD at 50% or even much greater in the setting of autism spectrum disorder. So here you have the classic scenario, and Luke's falling into this same scenario. His mom has looked on the internet at the DSM criteria for autism, and she's like, you know, Luke, he's really fixated on certain things. He's just not great with conversation. His social interactions are just kind of off. He's having trouble maintaining friendships. He doesn't appropriately adjust his behavior to different social contexts. So, you know, I really think he has ASD. So again, how are you going to parse this out? So I think it's helpful to think about the different bins that make up the ASD criteria, one of them being restrictive, repetitive patterns of behavior, interests, or activities, and one of the criteria being highly restricted, fixated interests that are abnormal in intensity or focus. Now, with ADHD only, a pearl is that kids can absolutely hyper-focus on things that they're into. And in fact, it's often said that ADHD shouldn't be called attention deficit because it's not that kids can't pay attention. Rather they have an attention allocation problem. They have difficulty shifting their attention toward things that are boring and more effortful. But for things that they really love, they can absolutely laser in on those things. But a key difference is that these things are usually not unusual for their age, that they're very interested in. So, you know, a school ager who's really into Legos, or a kid of any age who's really into video games, that is not atypical for age. Whereas for classic autism spectrum disorder, you'll see more of that strong preoccupation with things that are a bit more unusual. And so, I know the social communication questionnaire was mentioned this morning. There's a question on that some research studies have found helps to differentiate between ADHD only and ASD, and that is the question of preoccupying interest that seems odd to others. And they give the examples: traffic lights, drain pipes, timetables. So kids with ASD flagging for more of the odd interests, and ADHD only not flagging for this. Now, if kids do have high functioning, more mild autism spectrum disorder, sometimes their perseverative interest is more age typical, but it's usually there's quite an odd flavor about how they're presenting with that, at that more typical interest. So what about the criteria of insistence on sameness, inflexible adherence to routines, ritualized patterns of behavior? Kids with ADHD only tend to be more high on the novelty seeking, where kids with ASD tend to be lower on the novelty seeking. Kids with ADHD, you hear all the time about how much trouble they have following routines, whereas ASD, they're really, really stuck on their routines. As far as the bin of deficits in social emotional reciprocity, we have the criteria of failure of normal back and forth of conversation. Now we know that there definitely can be issues with holding conversation in ADHD. In fact, one of our diagnostic criteria is interrupting others. But a difference is that kids with ADHD they'll speak on a variety of topics, whereas in autism spectrum disorder, you get this more quality of being stuck on their preferred area of interest. They're always trying to steer the conversation back to that area that they're interested in and doing a lot of monologuing. As far as pop-up phrases, we can also see kids having these phrases that they've heard from videos or they've heard other people say, and they can sometimes just come out with these, and it has nothing to do with the conversation at hand, and there's no clear communicative intent to it. As far as reduced sharing of interests or emotions, so kids with ADHD, this is intact, the sharing. They, you ask the families and they bring things that they're excited about to show the caregivers. When they're excited about something on the street, you ask them, well, what do? They point at that thing and they look at it. They look at the caregiver. They look back at the thing as if they're trying to use the eye gaze to draw that caregiver in. So that's a really coordinated sequence that a typical kid would have, which a kid with autism spectrum disorder, you'll see deficits with that. And oftentimes you'll get this history that they're really only bringing things to the caregivers when they need some help with it. They need it to be the thing fixed, or they need the battery to be changed, not just, wow, this is really cool and I want to share my excitement with you. And then there's also the criteria of failure to initiate or respond to social interactions. So kids with ADHD only, that's intact. They initiate social interactions, although they could be really intrusive or off-putting in the pace or intensity by which they are initiating those social, they're trying to initiate social interaction. Whereas autism spectrum disorder, we see deficits in initiating. Of course, we want to be careful, because if a kid is depressed, then, they might not be sharing their interest as much. They might not be initiating social interactions as much. But a key difference for autism spectrum disorder is that, this is a pervasive long thing, that they've always been that way. Whereas if it's a depression-related thing, it's going to be, when they weren't depressed, they were intact and they were sharing things and initiating. But when they became depressed, then that's when you saw that reduction. So what about deficits in developing, understanding, and maintaining relationships? And the criteria of included in this one is difficulty adjusting behavior to various social contexts. So with ADHD, we often see kids acting, inappropriately. But a key thing is that it's often them being so hyperactive and impulsive why they're inappropriate, and they just can't hold themselves back, but they do understand that their behavior was inappropriate. So we have kind of a saying in the ADHD world, it's not a disorder of knowing what to do, but rather a disorder of doing what one knows. Whereas in the case of ASD, there really is this fundamental lack of understanding about what's appropriate for the social context. What about the criteria of absence of interest in others or peers? So for ADHD only, we're not going to get a big history of this. Whereas for ASD, on the social communication questionnaire, a question that was found to differentiate in research studies between ADHD only and ASD was this question about when the child was 4 to 5 years old, do they fail to comfort caregivers when the caregivers were sad or hurt, with the kids with ASD failing to do so and the kids with ADHD only not flagging on this. One thing I listen for in my evaluations is whether or not how the parents are describing the kids. Now, if they're saying, yeah, I really think he has ASD, but then they also say, well, he's really empathetic, he's really compassionate. Now, that would not be consistent with ASD. Or on the flip side, if they're saying, this kid really knows how to push other people's buttons, they're extremely manipulative. So with ASD, we know that it's this core inability to understand that other people have different perspectives and to perceive what those different perspectives may be. And so if you really know how to push other people's buttons and manipulate them, you can really perceive other people's perspective and use that. And so that wouldn't be consistent either. So what about deficits in nonverbal communication? The criteria of abnormalities in eye contact, body language, deficits in understanding or using gestures. So with ADHD only, we see this intact nonverbal communication skill development and skills. So a kid in this picture here, he's using a nonverbal gesture and he is accompanying that with eye contact. So that is that's very typical. Whereas with ASD only, we can see this, odd or wooden body language, or in some cases it's odd, but it's not wooden, it's more just exaggerated. The social communication questionnaire, a question that is shown to differentiate ASD from ADHD only, was whether or not kids fail to accompany requests with eye gazes or gestures. Now, I also, when I'm, talking to families, I'm looking at what the kid is doing and how they're looking at the parents. And, when I see a kid that, he's listening to what's being said and, he's kind of checking in with his mom, I ask him a question and he's like, okay, I'm going to answer this, but I'm not sure what mom's going to think. And then he's looking at the parents for how they're reacting to what he said. That is not so consistent with ASD because we're seeing, again, this reduction in the use of that eye gaze. Be aware, of course, though, that there's caveats to everything. So diminished eye contact is also often seen in shy, anxious kids when they're in unfamiliar situations. But typically, you're not going to see that being pervasive across situations. When they're with family or friends that they're close to, you see that eye contact improve, whereas ASD, you've got more of this pervasiveness. So those are just some thoughts about how to differentiate the two. In the case when you have ASD with superimposed ADHD, the kids really should meet full criteria. They need to meet full criteria for ASD, meaning they have qualitative deficits or differences in their verbal and nonverbal communication, their social emotional reciprocity, and they have the restricted repetitive patterns of behavior or interests, and not just one of those areas or just a splash of that. And then you need to have superimposed ADHD symptoms on top of that. All right.
So now we're going to talk about anxiety as one of the other differentials and comorbid disorders that accompanies ADHD. How many people are seeing an increase in your kids in anxiety? And are you screening for it? Asking a lot of questions about it? Okay, well, that's what we're going to talk about next, because we know that about 30% of children with ADHD have an anxiety disorder as well. And so part of what is really important to do is, if you have a patient who has ADHD, always ask about anxiety. And a lot of times parents don't even recognize that their kid might have anxiety, but I think it's really important to ask those questions. And so we know that this is associated with higher levels of somatic complaints in kids. So again, if you have a child with headaches, stomach aches, you also want to ask about anxiety. So what is anxiety? Anxiety is apprehensive anticipation or fear by the child of some dangerous occurrence in the future. At least that's their perception. And it's accompanied by unpleasant feelings, stress, tension, or somatic symptoms and signs. And an anxiety disorder is persistent fear or worry that causes significant distress and impairment of age-appropriate functioning, such as schoolwork, play, or interpersonal relationships. So again, that whole question about function is really important. If the anxiety, if a child, everybody has anxiety, but if the anxiety is so great that it's impairing the child's function, then we need to pay attention to it. And I'll just go over some basics. I don't want to spend a lot of time on it, but we know it's a physiologic response that protects individuals from danger. And we know that worries are the cognitive or thinking manifestations of fear and anxiety. We know it's one of the most common psychiatric conditions in children and adolescents, and we know there's a very strong familial tendency. So I think, again, that whole family medical history I talked about a few minutes ago, it's really important when you're picking up on signs of anxiety to ask about, does that occur in the family? Often I'll say to the parents, is it diagnosed or not diagnosed? Because somebody might be a worry and they might not be diagnosed with that. The age of onset is early as preschool years, but it may not be present till school age. And we know that girls have twice as much anxiety as boys do, and that's pretty common sense. So we, again, in terms of what is anxiety disorder, we know that there is a stress response. And I'm just going to jump ahead to the next slide, which looks at the autonomic nervous system. And so when we know that stress occurs, that we have a reaction in the amygdala, which then goes ahead and triggers the whole HPA axis in terms of changing hormones in the body. And so the stress response is to increase our amount of epinephrine in the body, which will increase heart rate, blood pressure, dilates blood vessels to vital systems, and the whole HPA axis is activated. The HPA secondary surge, once that epinephrine decreases, there's a secondary surge that releases the whole cortico-releasing hormone, ACTH, and then cortisol. And so what happens is that continues in kids who have chronic anxiety. They have that gas pedal on all the time. And so they're always in that fight or flight mechanism, and that is very continuous for them. And so what that can do is result in higher levels of executive functioning, decreased cognitive ability. So they can appear as though they have ADHD because they can't concentrate, they can't really think carefully, they can't do their homework. And so that becomes very stressful for them. And I like to sort of ask the question to kids, how does that feel to you? So this is, I think this is a good example that particularly in girls. This is a very common thing. I took a test, I didn't know the answer, so I failed the test. That means I'm going to fail school. That means I'm not going to go to college. So, kids just go from 0 to 100. They can really identify when you ask that question. Another example is I walked down the hall and this girl didn't talk to me. So now all of my friends are mad at me, and then I have no friends. And so this becomes very common, particularly in teenage girls. That's very common. So when we think about anxiety disorders, I'm just going to go through them really quickly because there are different types of anxiety disorders, but these are the different categories: anxiety, OCD, trauma, and stress-related disorders. And I think we talked this morning about the whole area of trauma and stress, and we know about adverse childhood experiences, that kids who suffer from trauma can really have problems with their cognitive thinking as well as high levels of anxiety. So we want to be sensitive to that and ask questions about trauma with kids. So here are some of the symptoms that kids will have when they do have a generalized anxiety disorder. They're easily fatigued, they're restless, they have difficulty concentrating. Irritability is a really big hallmark sign both for depression and anxiety. So if you're hearing irritability, that should really be a red flag for you to pay attention. If the kids were not irritable before and now they're irritable, because that's really a hallmark symptom. Muscle tension, and again, that's sleep disturbance. A lot of these kids will describe that they cannot fall asleep at night, that their mind is really going really fast, they feel very restless, or they have unsatisfying sleep. In generalized anxiety, the kids will have often concerns about what's happening next. And so they will think about what's happening in school tomorrow, or what's going to happen when I walk down the hall and I see that girl who bullied me, or all this sort of expectation anxiety. And the child cannot control the worry, so parents will say, well, just stop worrying. Well, that doesn't work. So, they can't control the worrying, and they find it very hard to do that. The anxiety can cause clinically significant distress and impairment across the whole area of functioning. And we know that it's not explained by something else. So these kids worry about the fact that they worry. And if you've worked with teenagers particularly that have anxiety, they really say, I'm tired of worrying. This has been really hard. I'm really tired of this. It's making me sad. I'm so frustrated. I just can't control it. The family has often made pretty major adjustments to work around that child's anxiety. You'll hear about parents who will have, the mother will lie with the kid for hours before they go to sleep because they need to talk about stuff and they process things. So, you'll have to ask questions about what alterations have happened in the family to accommodate this. Teachers often don't see this, and so they say these are really good kids because often they're perfectionistic and they do a good job in school. Another type of anxiety is separation anxiety disorder, and although this really does manifest itself in younger children, it can also manifest itself in your older kids, in that they really may have a very hard time going to school because of some trauma that happened in school. I've seen a number of kids who've been bullied and they're afraid to go to school because they had this trauma occur to them in school. So they don't want to separate from the parent. They have a hard time, with seeing that person that was the perpetrator, so to speak. Some kids will really worry about their parents and being apart from them, and they'll worry that something bad is going to happen to them, and that can be part of a separation anxiety. And then there's always the whole thought of anticipated separation, where kids are afraid to be separated from their parent. They think about that a lot. So we know that school refusal or school avoidance is a manifestation of separation anxiety. And then there are phobias. I'm sure you've all seen kids who've been afraid of bugs or thunderstorms, different kinds of things in their environment. And so that phobia can be very targeted and very specific, and the child will go to great lengths to avoid the contact with that. So that's another type of anxiety. Social phobia or social anxiety, I think that's very common, particularly again in sort of adolescent females, in that they are afraid to go to dances, they're afraid to go to social functions, they're afraid of how they look, how they're going to behave, they feel that everyone's watching them, and that this whole discomfort is experienced as fear as anxiety. And so this can be really disabling in some cases. And I know the whole thing about the use of a public bathroom, I don't know if you've run into that with a lot of girls, but they are very fearful of the whole public bathroom kind of thing. So here's a list of all the different, I'm not going to go through it just because of time, but all the different areas around social anxiety that you can see. Panic disorder, I think it's really important to ask kids if they're having panic attacks, because if they are having panic attacks, we need to address that. And that's where they have their heart beats really fast, they might have sweating of their hands, they can't breathe, and so that's really important to identify that as well. So in terms of the assessment, you're going to ask all these questions, and we need to use a timeline. Is it getting worse? Is it getting better? Is it interfering with your functioning? Okay, the other consideration is depression, and I'm sure you see a lot of depression as well. So we want to consider depression as a possible comorbid diagnosis for ADHD or a diagnosis on its own. We know that 2/3 of kids with depression will also have ADHD. They'll have a comorbid condition, and that can include ADHD. And so what is depression? Depression causes feelings of sadness, irritability, again, that decreased concentration. When kids are depressed, they're not going to concentrate as well, so they might appear as though they have ADHD. And the symptoms can be very mild, or they can be quite severe. We know the number of kids with depression is increasing, and every time I look at a smart brief or something, I see the numbers are going up and up. And so we know that is very concerning in our society. An episode of depression lasts about 8 months, and so it's important that when you are engaging kids in treatment for depression, that we engage them for about 9 months to a year. And we know that a depressive episode may reoccur within 2 years after they had the first one, so these kids are prone to reoccurrence of that. We know these kids to end up having not great outcomes, and that about 30% will develop a substance abuse problem. So treatment is very important. We'll talk a little bit about that. We know many of these kids have comorbid conditions, and they may go on to develop bipolar disorder. So the biggest worry with depression is suicide, right? And again, that number is increasing. We know of kids between the ages of 10 and 24, the number of kids with suicide is going up. It's very scary. And so here are some of the statistics about suicide. A depressed teen is 12 times more likely to attempt suicide than one that is not. And we know that there are cultural variations in suicide rates, that Native Alaskan youth have the highest rates of suicide, and so we really want to consider all of our patients in terms of the risk for this. So in terms of what the causes are, or what the risk factors are, not the causes, the risk factors. If there's a family history, again, that's important. If there's any other kind of psychiatric disorder, substance abuse, a child has suffered trauma or bullying, if there's psychosocial adversity, and chronic illness. Now this year, I don't know if you're familiar with the GLAD PC guidelines. Are people familiar with that? Okay, so if you are, you know that they just came out in February 2018. They changed a bit from what they were before, but you can really, if you don't know these, download them, keep them in your office, because these are really good guidelines for how to manage kids with depression. So there's a GLAD PC Part 1 and a GLAD PC Part 2, and one is assessment and the other is the treatment. And so what we're looking for with these kids and is that in primary care that you are screening to identify whether or not kids have a major depressive disorder, moderate or mild depressive disorder. And here are some of the symptoms that need to be present. There are 9 of them. There we go. So they're depressed most of the day, diminished interest, significant weight loss or weight gain, insomnia or hypersomnia, psychomotor agitation or retardation nearly every day, fatigue, feelings of worthlessness, decreased ability to concentrate, and recurrent thoughts about death. So what we're doing, what the GLAD PC will recommend is doing screening and then come up with your diagnosis, either mild, moderate, or severe. So what are some of the characteristics? In younger kids, it's going to be somatic complaints, psychomotor agitation, school refusal, phobias. But with adolescents, it's irritability, apathy, I don't care, low self-esteem. A lot of the things that Luke is having that we're seeing, aggression, antisocial behavior, substance abuse. And so when we start to assess kids for this, there's some basic rules that we need to establish. Obviously, confidentiality. You always want to interview alone and ask questions about suicide, and that there are no wrong answers. And so, using something called SIGI caps, I don't know if people are familiar with that, but it's an acronym that you can use to ask the questions about depression. It's very helpful about sleep, interest, guilt, energy deficit, concentration deficit, appetite, psychomotor retardation or agitation, and always ask about suicide. Sometimes people are afraid to ask about suicide, but I think it's really important to ask about it, because the kids who have been suicidal report that if someone had just asked me, or if they had a suicidal attempt, they might have not done that. So it's really important to ask about that. You're always going to do a good mental health evaluation, look at their affect, their characteristics of talk, and then do depression screening. So in a developmental PEDS program, we would be doing depression screening, but it should be done also in primary care for kids 12 to 18 years of age. And here's a list of the tools that you can use. Are people doing this routinely in their practices? Yeah, that's good, okay. And so the ones that are, the Beck Depression Inventory is a really nice tool, but it's expensive. But the Pediatric Symptom Checklist, the PHQ-9 and PHQ-2 are free. PHQ-A is modified for teens, and that's for free as well. So we know that ADHD, anxiety, and depression have many shared aspects, that all of them may have decreased concentration, and they all may involve academic underperformance, irritability, emotional outbursts, and sleep problems. Okay, I keep going? Yeah, okay. So we have ADHD versus anxiety and depression, in that the quality of internal distractions differ. There's an onset and persistence of symptoms. In terms of ADHD, there's going to be an early onset of symptoms. These will be persistent. But whereas with anxiety and depression, the onset could occur at any time. It doesn't have to be for a long time. And with anxiety, it can wax and wane, because the child may become anxious in some situations and not in the others. And certainly in the summers, a lot of kids, the anxiety goes away. And the inattention may get better when either anxiety or depression are better. I'll talk briefly about ODD, oppositional defiant disorder. I just want to take a minute to do that. Always consider ODD as one of your differential diagnoses. We know that that can also occur in kids, and many times in kids with ADHD. About 30 to 40% of these kids will have ODD. And these kids are just angry, they're irritable, they're tough. I mean, I really feel sorry for parents who have these kids. They're very defiant, they can be very argumentative, and also vindictive. And so here are the criteria for ODD, and this is something that we want to make sure that we are differentiating between what is ADHD and ODD. So the kids who have ADHD and ODD, in terms of the difference, there will be a failure to follow rules and directions. And with ADHD, this really is because the kids just are inattentive. They need a lot of prompting. It's not intentional. Whereas children with ODD, it's more due to the defiance and the refusal than it is the inability to pay attention. The annoying others piece that is part of ODD and ADHD is that the annoying others in ADHD is not purposeful, not intentional. It's just due to being impulsive and hyperactive. Whereas with ODD, these kids may often deliberately go out of their way to annoy others. Both groups of kids may have high activity levels and impulsivity, but generally that's not just seen with ODD alone. Okay, in terms of a learning disorder, I'm going to keep going. I'm sorry, we're a little confused on who's doing what. So if learning is a problem, you always consider a learning disorder. And this is a major thing that I think gets missed. 25 to 35% of kids with ADHD have a specific learning disorder. And Casey's going to be talking more about that, so I'm just going to sort of skip through that. And then there are always other disorders to consider in terms of our differential diagnosis. We want to think about bipolar disorder. I just want to call attention to gender dysphoria. Not all kids who identify as gay or transgender have gender dysphoria disorder, but we know that they are at a higher risk for either depression, anxiety. Many times these kids may have ADHD, but gender dysphoria is really unhappiness or discomfort or distress because there's a mismatch between their biological sex and gender identity. So not all LGBTQ individuals will have this. Conduct disorder, we need to consider that, certainly substance abuse disorders, and always genetic disorders we talked about today. Okay, we're going to take a break for about 10 minutes, but let's ask questions first. We have about 5 minutes for questions. Anybody have any comments, questions in the back? Here we go. If we can use the microphone, that would be great.
Yes?
So I work in child abuse, and so it's really difficult for us to kind of fish out which is an adverse childhood experience versus what is a true depression, anxiety. I mean, we see our kids and they come in with absolutely everything. So we can't get our kids in to see anybody for any, I mean, it's a year to year and a half. I live up in Portland. And so how do we help these kids in the meantime? So to fish out what is really any of these specifics, or do we just treat them for everything?
Is it okay if I answer this? So we're going to talk about the use of screening tools in a little bit. Casey's going to talk about that. But I think it's really easy to use some screening tools to help you with that diagnosis. So we're going to talk about the SCARED. We're going to talk about the PHQ-9s, or the one for adolescent. They're, do the ADHD screening tools. So you're really going to do all of them and try to sort out where is the functional impairment. Again, it comes down to functional impairment. And if there's a functional impairment, then you treat that. And you know, baby, where it's come from. You know there's trauma, but you have to treat the functional impairment in an appropriate way. And so you can't ignore that. And, we would recommend for all those kids that they're getting therapy, that they're, being treated for that. But if it's interfering so much with their schooling, or if they have a learning disorder, you just treat them the same way you would someone else. So that's what I would say. I don't know if you have any other comments? Okay. My team agrees with me. Okay. Any other questions? Yes. Yes. Oh, yeah. Yeah. Yeah, I end up seeing a lot of those kids. So the selective mutism is where children don't talk between the ages of 3 and 6 years of age, and they often will go to school and not talk, but they will talk a lot at home, and they talk with their family and whomever they're comfortable with. The challenge is that therapy isn't very effective for those kids because they don't talk to the therapist, and so that makes it really hard. I'll just jump ahead and say I do treat those kids with very, very small doses of Prozac, and it works. But I'm talking about 4 milligrams, 2 milligrams. Do you agree?
Yeah, absolutely. Yet oftentimes they do need the SSRI to break out of that.
Yeah, and that helps them. And then generally they do outgrow it, but they end up being shy as they've been older. It's it's an anxiety-based disorder.
Speak, and then all of a sudden she became mute. There was no event at home, anything that happened. Now she's not talking at school, at home. SSRIs haven't done anything. Now she does. We did some genetic testing, and she does have a genetic disorder.
Yeah.
But I don't know.
So that might be a good case for developmental peace.
I think
Come on, please.
when you asked about if there was an event that happened at home, were the caregivers in the room, or was it with the child alone? Because I think I would. Mm-hmm. Yeah.
There's no. I mean, she hasn't been alone with anyone. She hasn't. Oh, I'm sorry. She asked me if the child had anything happened at home, maybe when the caregiver wasn't there. We can't pinpoint anything.
Yeah, but sometimes the kids don't want to say in front of the caregiver, so it's really great to ask them by themselves.
But what if she doesn't talk? I mean, she just. I mean.
Well, that's
Well,
a good
I mean, that's
point.
just
Yeah.
it. I mean,
Yeah.
I'm not saying that to be funny, but I mean, really, even
but,
trying to borrow
yeah, so
stuff.
it sounds like the caregivers don't know of any. Does anybody at school know of something that happens? Because I find it hard to believe that there was no inciting
Something
event
that triggered
whatsoever. There's got to be some triggering event. It's trying to get
to that.
to ask about that.
But thank you.
Yeah.
I just wanted to ask about the empathy issue with autism, and I know that kids with autism have decreased social emotional understanding. And that question comes up a lot where parents say, but they're so empathetic. And, do we feel that kids with higher functioning autism, who are kids who are able to read the social cues of their parents or those that are more known to them, can we say that kids with autism have no empathy?
Well, we don't want to say that. Is this working? Yeah. So we don't want to say like, oh, they have like no empathy, whatsoever. But for it to be like an extremely prominent characteristic just wouldn't be typical for a kid with autism spectrum disorder.
Hi, I wanted to ask about any special considerations for those children who were affected by drugs in utero. I didn't hear it brought up this morning, and I haven't heard it yet, but I've been seeing a lot of it in the office.
I would just say that I would evaluate them the way you do everyone else, because we know they're at greater risk for having any of these conditions. And so you just would treat them the same way, because we just know that they're at a greater risk. Just like a child with prematurity, or alcohol exposure or whatever. So I think that's the whole opioid addicted kids. We're going to see what happens to them as they get older, because we are just only now understanding as they get older what the implications are.
I was just wondering if there's anything new out there, or
I don't know of anything new, but I would just make sure that you look very carefully at things that they're at a higher risk for. We know that they're at a higher risk for things such as attention difficulties, executive function, emotion regulation problems, as well as learning difficulties, often in the area of math, and difficulties with adaptive functioning. Often adaptive functioning is lower than intellectual functioning.
Any other questions? Okay, I think we're going to take a 10-minute break, and we'll see you in a few minutes. Thank you.